The next person on our program is our featured faculty research. And this is Dr. Sherry Wren, who is a professor of surgery. She's also the vice chair for professional development and diversity. She's the director of our global surgery program at CIGH. I'm not going to spend a long time talking about Sherry's awards. I do want to say something because there's been a lot of talk about lack of women leadership at Stanford recently. So I do want to just mention that Sherry was actually elected the governor of the American College of Surgeons, which she actually served as for 5 years. And she won the International Humanitarian Award from the American College of Surgeons this year. She's written the surgical guidelines for Ebola, and today she is going to share a little bit about her research. Sherry.
Thank you. Well, I was really honored when Steve Luby asked me to do this, but then it became a big challenge for me because I had to figure out what I was supposed to talk about. So what I first wanted to do is talk about this whole new field that people keep hearing about, which is called global surgery. Global surgery is, finding a definition is going to be hard, but for academic surgery, this is a difficult thing to try and figure out how to fit in. Because how do you insert this into the cost and value of a department? Especially surgical departments are highly RVU driven. And if there's no funding mechanisms and everything, as they say, no mission, no money. So, or no money, no mission, I guess. But there is substantial interest amongst medical students, residents, fellows, junior faculty, and even senior faculty. But what's very interesting is that there was just, it's going to be published fairly soon, we just wrote this. We surveyed so-called global surgery faculty from across the United States. We could identify 62 of them in all of the academic medical centers. And if you look at this, 58% of them are basically doing it on their vacation time. So this is not part of an academic department. It's beginning to become recognized as a viable career path, but we've got a lot to go. So what are we going to call global surgery? So this was a definition from Lancet, which is really studying research, practice, advocacy for prioritizing health outcomes. I sort of think about this as really healthcare's disparity research in low and middle income countries that's focused on surgical disease, treatments, quality and process, implementation, outcomes, and delivery models. So why do we care about surgery? I care about surgery because I'm a surgeon, but why should the rest of you? Well, about 1/3 of the global burden of all disease is treated by surgery. Currently, less than 6% of operations done around the world are done in low and middle income countries. And the Lancet Commission on Global Surgery said that we had to actually get to 142 million additional procedures per year before we eliminate this disparity. So as we see the rise of non-communicable diseases, surgery plays a critical role in diagnosing, treating, and palliating these diseases, and it's also critical to humanitarian responses. So this just sort of shows what the impact of a single disease is around the country and mortality around the world, and that's injury. So injury actually takes more lives than HIV, TB, and malaria combined. The amount of money going towards injury treatment, injury prevention is microscopic compared to the other communicable diseases. So, sort of a timeline. Actually, in the early 1990s, Charlie Mock, who's a colleague of Dean Jamieson, was actually living in Ghana. And his was really some of the first papers that started looking at surgery in low-income countries. Chris Lavy, who's actually an English professor in England, also was in Malawi at that time, sort of doing similar things. I think Charlie Mock's relationship with Dean Jamieson resulted in surgery for the first time in this Disease Control Priority 1 volume. Kind of waits a long time before anything sort of happens. 2005, the WHO sort of finally gets in and talks about emergency and now introducing this word essential care, so surgery is part of essential care. 2008, in an article by Paul Farmer and Jim Kim, they finally sort of said that, surgery is the neglected stepchild of public health, and that more than 15% of the world DALYS are lost because of inability to have surgery. And then 2015 was a big year. We saw a passage of a World Health Assembly resolution that made surgical care part of basically primary health care. There was a DCP-3 that was put out that included surgery, and then this Lancet commission. So if you look at the original DCP-1, surgery composed 14 pages. That's it. All the disease control priorities in the world, we got 14 pages. And that's sort of just a listing of what sort of was in there, which is fascinating. Hip replacement surgery, not quite understanding, okay. And then 2015, it actually got its own volume, 442 pages now, so we have come a long way. And they really broke it down into the global burden of these surgical conditions, interventions, platforms, policies, and economics. So this is what I could currently find on NIH Reporter, trying to find who has funding in the United States for surgical projects. And the vast majority of these are actually for increasing research partnerships overseas, except for this one in metabolomics. And there have been some foundation grants. Surgery was included in the Rwanda HHP program. And then the GE Foundation just gave a lot of money about a year ago to this Safe Surgery initiative. So, like many things, there's been an evolution of this research. So first you find papers that talk about the weird case, what did we do, look at this strange thing. Then you start seeing retrospective cases, audits, logs. There's a whole lot of that. Then they start getting into registries. And for the first time now, we're beginning to see some actual real research coming out. But it is taking a while. So who do we have at Stanford? We're growing slowly. So Tom Weiser, who's been here for a number of years, Tiffany Chow, who's sitting over here, who just joined us last year, Lisa Knowlton, who's just joining. Then we have Jim Chang, Shakti, Matthias Bruzzoni, George Yang, and myself. So we're all sort of, that's the potpourri of where people are working, what they're doing. So we're just beginning to sort of get here. So what did I do? So I actually didn't start off as an academic. I started off as service. So I started working with Doctors Without Borders as just for something I wanted to do. That was my introduction into this. And I used my vacation time. And the first thing I did is sort of said, wow, we don't really have the skills to be able to work in humanitarian settings. So I actually started and run the only course available in the United States to teach skills for this. We're having it in 2 weeks. We've trained over 450 physicians since 2010, so this is something I'm very proud of. I then started my research programs with the only source of funding I could find, and that's our Stanford Med Scholars, and which has been great. But it's also always one-offs. Every year you get a student or 2 students, and the projects don't have any life. We started our education partnerships through Michelle's MEPI with Zimbabwe. I did some time working on Ebola and surgery. Actually wrote a book about it. Then got into multi-country partnerships for education and training consortiums. And currently, my research is really focused in 2 areas. It's gender and surgical access in low and middle income countries and humanitarian. So I would say I didn't really start doing research in this area till about 2011. And I kind of broke myself down. Where do I write? I write about humanitarian, I write about burden of disease, I write about delivery and access. I mean, so you can see this is not a focused research program at this point in time. So this is pictures from my course. We have our own Paul Wise up there, who I give a lot of credit to as a pediatrician, decided to come and learn additional skills, but we have both an OB section and then a other surgical skills section. So this has really been something that Stanford has become known for, but this is not really research, it's education. So looking at sort of our 2 areas now, gender disparities in the utilization of surgery. This is a really complicated issue because disease prevalence will obviously look at case volumes. So men don't get pregnant. So if you just look at C-sections, by definition, men are not going to get it. And women don't get hernias as much as men. So we have to figure out how to do this. And there's many reasons why women might be underrepresented in these data sets, less value, all sorts of issues that we need to start sorting out. This was really the first, this is an international collaborative that looked at just all people. It was done by medical students around the country that collected data, anybody getting an emergency intra-abdominal operation except for a C-section. And what you can see here is that as you go from high, middle, to low-income countries, women are 51% in high, all the way down to 38.7 in low. So there's a loss of women along the way here. And you can't explain it by trauma. Men in every data set always have more trauma than women. So there's something going on. What is the something? So we started looking at it. We did a study in Cameroon where it's most of Africa, you have to pay to get your health care. And we actually looked at why would patients who've already paid to see a doctor, need an operation, refuse to do it. And sort of the bottom line in here is that being a woman and not able to sort of crowdsource your funding because an operation is expensive is really the most significant reason as to why people are refusing surgery. All right, it wasn't a big surprise. Why? We're beginning to try and ask why. This is actually some very preliminary data that we just did this last summer in another country, which looked at a bunch of surveys about gender perceptions and prioritization. And the dark gray bars are women, the light gray are men, and this is whose care do you prioritize first? And what you see is women prioritize care of men over care of women. So this is an important thing to sort of think about. We then started looking at it in conflict. So Doctors Without Borders actually does not charge anybody, so you take cost out of this. And we actually have the operative case logs and all sorts of data from both conflict and disasters. We only looked at conflict. Natural disasters are, again, a very different thing. So all the red countries are conflict countries. This is a huge data analysis. We ended up getting close to 50,000 surgical data that we can look at. And this runs from countries from Africa, Middle East, East Africa, so it's a pretty wide range. We've looked at literacy, dominant religion, all sorts of variables. And what's interesting is when you think about conflict zones, everybody thinks about, I'm just gonna skip this one, about trauma, like you're getting blown up by bombs. But it's actually a fairly small percentage of this data. More trauma is actually because of what's called nonviolent trauma, car accidents, burns, things like that. And there's gonna be gender differences here. And then when you begin to look at all the other humanitarian needs, so people still get appendicitis, they still have ulcers, they still have wounds, what happens here, you really begin to see a difference in who's getting care. And this is, again, all care is being paid for by the aid agency. And when we run all this analysis for all these factors, yes, men have more trauma, fits with every data set. But men were also much more likely to have surgery in Muslim countries. Women had more surgeries after complications for traditional medicine. And there was really, we can see you cannot explain these gender differences based on disease. So we're trying to move this work forward. And if we can't figure this out, we're not going to get to gender parity in health in low and middle income countries. And I think it's really going to be multifactorial as to the reasons why and how we intervene. So I would like to thank CIGH for just awarding us this grant. This is our other area, and this is really humanitarian responses. This is modern conflict. It's very different. And there have been incredible advances in the military after we've been at war for so many years. So the amount of mortalities now for coalition forces is the lowest it's ever been. One is they have a joint registry so they can actually look at it. We've invented these things called damage control resuscitation, tactical combat care. We've changed how we transfuse. We have organized trauma responses from literally right where somebody's injured all the way back to rehab. So it's an incredible advance. Modern conflict has changed, though. We now have these severe, protracted civilian exposures to conflict. We have interstate conflicts because it's not one country going to war against another country. These are interstate actors. Civilians and healthcare workers are being targeted, being used as human shields. And there's urban fighting, which we really have not seen in a long time. You also have a massive number of refugees who really have just basic healthcare needs. So this is unfortunately what this looks like. You have burns, hernias, women who are pregnant, children with problems, military injuries, and these are being handled in a really kind of outdated system. So we have no cohesive system as a humanitarian for these responses. For the military, Geneva Conventions really govern the rules of care. You have to care for civilians that you've injured. But if you have an insurgency or anything, there is no obligation of care, so people aren't getting care. Our current humanitarian model was really made in the 70s, and we've not yet translated these military advances into civilian responses. So the civilians in these settings like Yemen, Syria, Bangladesh now with the Rohingyas are really left without great responses. Also, as the security issues are getting worse, there are, for the first time, humanitarian care is being outsourced to contractors. So there's a lot of challenges here. And what we're going to do is we actually, because we have collaborators within the military, we're looking at these databases in conflict zones to look at what do you need for skills and capabilities. We're going to have an expert consensus of this and then actually make guidelines. So if there is a contractor that's going to be hired, we hope to say, here is the portfolio you must be able to put out there. And I think what I hope I've convinced you is that global surgery is new and emerging. I think by collaborating between high-income and low-income countries, we can really improve and inform surgical care. Our educational initiatives really do help in capacity building overseas through better education. And humanitarian care really needs a systems reboot and upgrade because it has not been looked at in a while. So thank you. Be happy to take questions. I got Denisha with the signs up. Stop talking.
Any questions for Sherry?
No questions.
Sherry, I have a question. I have a question. Can you talk a little bit about the burgeoning interest in students in global surgery?
Wow, that's a very complicated question. I think that if you put it, a lot of students are interested, and I think a lot of it in many ways is wanting to go and work overseas. And I think we also have students who are interested in primary research overseas, but a lot of the interest is literally, how do I kind of plan my career to be able to have international time to work overseas? And I think, and the problem is in academics, as all of us know, no department is going to pay a faculty member a salary to go do clinical care overseas. That's just not part of a model. So if you want to work in academics, we're going to have to figure out how we make this education and research based, because then it can fit within the portfolio of a department. So what I have to say, when I talk to a lot of students and you query them, what does that mean to them? It's almost exclusively about service work. And I think you can do service work without making it a career path. So where do they fit it in? I'm not sure. We are trying. Tiffany, thank you for getting up.
Thanks so much for your talk. As always, it's always fascinating to hear the things you've been doing. In terms of the humanitarian skills course, you know, Paul Wise, as pediatrician, went there. I attended it. There's been a lot of different levels and careers of people who have attended. I was wondering if you've done any follow-up with the people who've gone in terms of what people end up doing. Has anyone utilized the skills they've learned to work in a low resource setting?
So we've done surveys and we get things back. My favorite is I just got an email yesterday saying, thank you, I was a student in 2016. I was working in an Amazon remote hospital 7 hours up a jungle river. So we do get back individual responses. They actually responded more in some ways than to the survey. One of the fascinating responses, though, is we had a guy from Texas who took the course, who then, he's in rural Texas, has no access to plastic surgery, and actually was able to incorporate some of the techniques we taught in the course into his practice in rural Texas. So part of the problem is many people take the course and then they still don't go work overseas. So I don't have great data. I have really more anecdotal, like, thank you, you know, I was able to do X, Y, and Z. And
Sure.
so.
Sounds great.
Yeah.
Thanks.
Hi, Sherry. Thank you. Great talk as always. So I get to follow you on Facebook and as a colleague at the VA, and I see all the work that you do surgically in West Africa or in Africa that you've done for many years. I was wondering what you see in female surgeons in these countries and whether you see them being trained, whether you see them being respected, whether you see them being mentors, so that they can also provide gender parity in the operations and among their colleagues.
Thank you for asking, because that's actually a pet project. So there's a burgeoning movement of women in surgery in Africa. There's actually, you can follow them on Twitter too. And we have worked first in Zimbabwe with a women's interest group in surgery, and I'm seeing huge advances in that. I mean, there are almost no women within surgery in a lot of these countries. I was just in Vietnam and they'd never seen a woman surgeon before. So it is an absolute pet project, and we're really seeing it take off. So.
Thank you for your talk. I was wondering if you could talk about technology within the context of global surgery, whether that's robotics or whether that's using AI for wound care. Just wondering what your thoughts are there.
So one of the biggest problems about technology and innovation is actually systems of delivery. So you can't get basic supplies into so many different places. So if you look at laparoscopic surgery, which is, you know, since 1989 in this country, we're just beginning to see it go into Africa, and part of it's just supply chain. So robotics, a $2 million, I'm a robotic surgeon here, a $2 million robotic machine being put in and then being able to supply it isn't gonna be possible for a while. So there's just massive supply chain issues, and actually suppliers are pulling out of Africa for some reason. So that's where we need the innovation, how to get things in.
Thank you very much,
you.
Sherry.